Well, thank you very much for being able to talk to you about the latest developments in renal cell cancer and urothelial cancer. My name is Arnulf Stenzl. I'm coming from Germany. I'm head of the Department of Urology at the University of Tübingen in the southwestern part of Germany. At the same time, I'm the chairman of the scientific committee of the European Association of Urology. Uro-oncology nowadays is actually a treatment strategy which is done by an interdisciplinary tumor board. It's urologists next to oncologists, next to radio-oncologists that are actually sitting together and making the strategy for the patient. It should be a joint strategy for the best of the patient. In urothelial cancer, we have two different kinds of diseases. One is which is localized, confined to the bladder, sometimes even confined to the mucosa or submucosa. Those are the types of tumors where you try to preserve the actual organ without having any compromise in the oncological outcome. This, of course, increases the quality of life of the patient. And now with the development of medical technology, we are able to do that in a much higher percentage. Not only preserve the bladder, but also the kidneys in the cases of upper urinary tract cancer. Once the tumor has really become invasive, and either there is a danger of becoming systemic by having tumor cells that are in the bloodstream and the lymphatic vessels, then we either have to do a radical surgery, more radical surgery in case of the bladder. We have to remove then the entire bladder and the surrounding lymph nodes. But we also have to think about the quality of life, especially in the younger patients, and try, if we cannot preserve the organ, then to reconstruct the organ and making a neobladder. We have excellent tools now to do that. Now, in those cases where we think there might be additional systemic spread of the tumor cells, even sometimes we don't see it, then we have to think about adjuvant treatment. Or if we do have overt metastases, then we have to either do a chemotherapy or immunotherapy. We, of course, try to make the best outcome, even in a presumably localized disease, but muscle-invasive disease of the bladder cancer. In those cases, we try to give a neoadjuvant systemic therapy. Chemotherapy, so far, for the last 30 years, this has been cisplatin-based therapy, but in recent years we have had new tools with immunotherapeutic agents, which then can be given neoadjuvant in a neoadjuvant setting with less side effects, and those side effects allowing us to do either faster surgery or surgery with less complications. Now, renal cell cancer is a cancer where we usually, or in the majority of cases, have the disease more localized. And with today's imaging possibilities, we tend to detect this cancer at a stage where it's not only localized, but it's also at a size or at a location where we can remove it without taking out the entire kidney, so it's more a kidney-sparing surgery. And that nephron-sparing surgery or partial nephrectomy can now be done less invasive, it can be done minimally invasive, and with the possibility of using additional imaging, either with 3D reconstruction on the imaging part or using fluorescence during surgery, we can spare even more of the kidney and allow, even in solitary kidneys, to have a functioning functioning kidney, despite the fact that we had to remove the tumor. So that is definitely something which has been developed in recent years with robotic surgery now. It's further advanced. It gives less side effects due to a less ischemic strategy during the surgery. And also now we are trying to get in the more advanced disease a adjuvant treatment in addition to the localized surgical treatment. Now we have had several attempts to have adjuvant treatment for aggressive renal cell cancer. We now did try to differentiate between the different histologies, but also we have had not very much success with recent, or with not with the recent, but with the previously existing systemic therapy. Now with immunotherapy invading, so to say, renal cell cancer, now we have better possibilities of even using it in an adjuvant way, because it has less side effects and it may give that immunogenic tumor, which we presumably have in renal cell cancer quite often, to give that a higher chance of cure, despite the fact that this tumor may be aggressive or may already have started to become systemic, despite the fact we don't see it on imaging. So immunotherapy really gives us new ways, new strategies in renal cell cancer, and trying to get cure in a higher percentage of patients, which was not possible before we had those new substances.